So this is about abdominal anatomy, first PDF from StudyMEDIC PDFs. So let's see. This is about the layers of abdominal wall. So this is outermost is skin and superficial fascia, then deep fascia. It's also called as scarpas. We get confusion most of the time. This is important. Scarpa is deep and camper is superficial. So skin, next SC, then again there comes deep is scarpas fascia. Then deep fascia has got some other layers, investing layer, superficial layer, intermediate and deep layer. In this way there are further layers in the deep fascia. Outermost muscle is external oblique, middle is internal oblique, and innermost is transverse abdominis. These are important because they are continuing into the scrotum, continuing into the inguinal canal. So that's why these layers, once we have to understand, outermost is skin, then there is campers or superficial fascia and scarpas. SCS, deep fascia is scarpas fascia. Campers fascia, fatty superficial layer, scarpas is deep fibrous layer, muscles external oblique, fascial transverse. Now medial anterior wall of rectus sheath, medially you get posterior wall of rectus sheath, peritoneum. Fascia of anterior abdominal wall, superficial fascia is the lower part of anterior abdominal wall, divided into two layers. It corresponds then superficial fascia or campers fascia. Again, just try to remember superficial fascia, campers, deep fascia, scarf. It corresponds to continuous with the subcutaneous fat. Loses its fat in the penis and perineum. This is important. So superficial fascia has no fat, so it continues as without fat. Extends to the thigh and corresponds and reflects backward superficial layer of perineum. Deep membranous layer or scarpas. This is deep. Scarpa, superficial, camper. So this confuses. Instead of that, superficial and deep. Scorpion. Just try to remember scorpion. It is hidden down. Camper. The word is just like similar, but it is camper is outside. Superficial. It is condensation of superficial fascia. Midway between umbilicus and pubic symphysis. Superior it fades away between the pubic symphysis. Inferior it goes below the external ring and name as. Now this is another confusing part. Inferior below the external ring, the name changes to Colles fascia. This scorpion or scarpus fascia becomes Colles. Laterally attached to fascia lata and below to finger blade inguinal ligament. Okay, Colles fascia. Superficial fascia. It is a continuation of scarpas fascia. So perineal fascia, the Colles fascia is continuation of scarpas, and campers fascia, which is superficial, it becomes superficial perineal fascia. Now see the one more confusing part. In abdomen there is superficial, there is deep. Superficial is deep is scorpion, scarpa, and this is camper. In perineum, this is in abdomen. Now when you go into perineum, this scarpa, superficial perineal fascia, it is becoming Colles. It is continuation of scarpas fascia. It continues into Colles. Extends over the penis and scrotum, giving to facial coverings. The muscles of superficial part of perineum. So this is perineum, now penis and scrotum. So let us see, because of this specific attachment to the fascia lata, fluid tracking down from above under the superficial fascia cannot extend into thigh. So this is regarding when there is injuries to the urethra. So this is about extravasation of the urine. Muscles, there is no issue of this. External, internal, transverse abdominis, rectus, pyramidus, cremastic. Conjoint tendon is found with lower part of both internal and external internal and transverse, not external. It is the combination of internal oblique and transverse abdominis. It is inserted to pubic crest and iliopectineal eminence. It forms the strengthened medial part of the inguinal ligament. Continues medially or with the anterior wall of the rectus sheath. Innervation is ilioinguinal, conjoint tendon is innervated by surgical weakness predisposed to indirect inguinal hernia. Injury to ilioinguinal during appendicectomy involves paralysis of conjoint tendon. So this leads to conjoint tendon prevents direct hernia from descending to the scrotum. The defect is fascia transversalis is a thin fascia which lies the inner surface of transverse abdominal muscle. It forms the posterior wall of the rectus sheath. The arcuate line. This is fascia transversalis, posterior wall of the rectus sheath. When you take the P-fenestral incision, this is the wall layer which is coming. Deep inguinal is the opening in the fascia transversalis. Now this is about rectus sheath. You see here the layers, skin, subcutaneous tissue. This is rectus sheath, anterior layer, posterior layer, and here there are laterally you are getting external oblique aponeurosis, internal oblique aponeurosis, then transverse abdominis muscle. Then below that is the transverse fascia and peritoneum. So this is at the level of arcuate line. This is below the arcuate line. What happens below arcuate line? There is directly in the center when you try to cut, you get transverse fascia only. You don't get these 1, 2, 3 layers are not seen in the center. Here what happens? This is aponeurosis of external oblique is anterior and it splits and it also goes back. But below arcuate line, both these they come in the anterior. So there is deficiency. So linea alba is a white line in the midline found by decussion of the aponeurosis of external internal oblique. Extend from the xiphoid process to symphysis, it is avascular. Linea semilunaris. This is the question asked. It is lateral border of rectus sheath extending from pubic tubercle to the tip of 9th costal cartilage above. So this is linea semilunaris. Arcuate line is a crescent line situated between upper 3/4 and lower 1/4 of posterior wall of rectus sheath. This is vertically rectus sheath is there like this. So it is upper 3/4 and lower 1/4. If you divide this into 4 parts, so 1, 2, 3, 4, it is upper, it like this. Here is some. This is the arcuate line. Linea semilunaris is a lateral at the lateral border of rectus sheath extending from pubic tubercle to the tip of 9. This is linea semilunaris. It is vertical line and arcuate is the transverse crescentic line. Fascia lata causes arching of the inguinal ligament downwards. Yes, it puts downward. Fascia lata is continuation of fascia transversalis below iliac crest and fascia transversalis continues fascia lata. Any intra-abdominal organ may herniate except pancreas because it is guarded posteriorly. Blood supply of the anterior abdominal wall, internal mammary artery through the terminal branches, superior epigastric artery and musculophrenic artery. External artery through 2 terminal branches, inferior epigastric from below. This is superior epigastric artery from above, descending out at end postal arches. This is the blood supply. You can see like this. External oblique aponeurosis is here. This is external oblique. Superficial circumflex iliac. This is superficial circumflex iliac. Then superior epigastric artery is superior epigastric SE. Then deep circumflex iliac. This is superior epigastric. This is inferior epigastric, deep inferior epigastric 2. Then deep circumflex iliac like this. Superior inferior superficial epigastric artery. So these are so many arteries from below and arteries from above. They are forming this anastomosis around this. This is important. See, this is external iliac artery. This is inferior epigastric artery, which forms the lateral boundary of Hasselbalch triangle. This is the rectus sheath. This is the inferior epigastric artery, rectus sheath, like this, and this is the Hasselbalch. Inferior epigastric, superior inferior epigastric, inferior epigastric. This is superior, coming from above. So skin around the umbilic is supplied by T10. This is the question. Referred pain of appendicitis at T10. Lateral thoracic vein anastomosis where superior epigastric. This is again question. So this is lateral thoracic vein and superior epigastric vein. Neuroscale vein lies between this. Umbilical folds. Again, this median is center, which umbilical ligament which contains urachus with the bladder. Two umbilical folds laterally. These are the umbilical arteries. These are umbilical arteries which drains the deoxygenated blood. They drain deoxygenated blood from fetus to placenta. Fetus to placenta, and two umbilical folds on the. These are the lateral inferior epigastric vessels. Inguinal canal passes anterior abdominal wall. Internal ring is on the opening fascia transversalis, half inch above the midpoint of inguinal ligament. External is external oblique aponeurosis, two pillars, one in the pubic tubercle and one on the pubic symphysis. So it is always medial. Pubic tubercle is one and another is pubic symphysis. So this superficial inguinal ring is medial to pubic tubercle. The direction of the canal is downwards and medially. That's why inguinal hernia is always above and medial and femoral hernia is below and lateral. That is the question. Inguinal hernia above and medial, and femoral hernia is below and lateral. This is the difference. So anterior wall, you can see anterior wall is made up of external oblique, fibrous and transverse abdominis. Posterior wall is fascia transverse conjoint tendon. It rotates on the medial side and goes becomes the posterior wall. Roof is formed by internal oblique and transverse abdominis. Floor is inguinal ligament. So if you see roof arching fibers of internal oblique. In male there is spermatic cord and ilo-inguinal nerve. In female surrounding ligament ilo-inguinal nerve. Inguinal triangle is also called as Hasselbalch's triangle or Halstead triangle. This is the another word. Halstead triangle. Part of posterior wall of inguinal is divided by laterally by the umbilical ligament. It is divided by lateral umbilical ligament into medial and lateral parts bounded laterally by inferior epigastric vessels. This is the inferior epigastric vessels. Medially is the lateral border of the rectus. It is a triangle through which direct hernia passes. Indirect is more common in old age. So indirect has to be from the lateral side, and direct is directly here, medial to ligament. This mechanism acts to prevent herniations. Inguinal canal shuttering mechanism. Arches of the transverse abdominal, attachment of the deep inguinal posterior transverse abdominal, so the contraction of the muscles. Inguinal ligament form the lower border external because of lower border external oblique muscle. The anterior is spun backwards and mid inguinal point is midpoint of pubic tubercle. And this is the question. Midpoint of inguinal ligament and mid inguinal point. This is pubic symphysis and here is pubic tubercle. This is the difference. ASIS is common. ASI is common for both. For midpoint of inguinal ligament, it is extended from the pubic tubercle, and for mid inguinal point, it is from the pubic symphysis. Superior lumbar triangle. This superior lumbar is superior is the rib, laterally is internal oblique, medial is sacrospinal quadratus lumbar. Inferior it is also called as. So these are the triangles. Contents are this. This is again the layers of the scrotum. Skin is continuous. Scarpa's fascia. What we have seen. Campus is superficial and scarpus is super deep in the abdomen, which continues as a Colles fascia in perineum, but here it continues as a dartos muscle. Scarpa is scorpion, it is deep. Fascia of abdomen, Colles in perineum, and continues as dartos muscle in the scrotum. So scarpas is deep and campus is superficial. It has nothing to do here in the scrotum. External oblique, internal oblique is cremastic. This is question. Cremastic fascia, cremastic muscle is formed by internal oblique. Transverse is also forming it. And internal spermatic fascia is formed by external is formed by external, internal is not by internal oblique. Internal oblique forms the cremastic fascia. So internal spermatic fascia by transverses. So this skin, then dartos. Dartos is, this is the question. Dartos is formed by the scarpa's fascia. Planes of the abdominal wall, these are the nine quadrants. Transpyloric plane, pylorus is there, fundus of gallbladder is most commonly asked, pancreas is also there, second part of the duodenum is there, then hilum, end of spinal cord. L1 in adults is also there. Psoas muscle, psoas fascia, this is not important. So question is origin of psoas major. Front of the transverse, this is question. Front of the transverse process of L1 to L5 actually. Front of transverse process of all lumbar vertebra. T1 to T4, lumbar, not L. I think it is posteriorly transverse process is inserted sympathetic triangle. So what is there laterally? This is about relation of psoas muscle. Anteriorly, kidneys, ureter, gonadal vessels, no issue. Specific for the left muscle, fourth part of the duodenum. Posteriorly, lateral caudal area, ileoepigastric and ileoinguinal. These are lateral. Lateral cutaneous nerve, thigh is also lateral. It's coming from the lateral side. Figure is not given here, but it's from the lateral side.